Hello, everyone. My name is Rebecca Stern, and I will be introducing the second panel today on interoperability, digital transformation, and enhancing patient care. Michael Bouton, MD, MBA, is a practicing emergency medicine physician and the Chief Information Officer of New York City Health, the largest municipal health system in the country. He completed residency at the Harvard Emergency Medicine Program at Beth Israel Deaconess. Sara Dillon serves as the Chief Data Officer at Henry Schein. She is responsible for, among other things, artificial intelligence capabilities across the Henry Schein portfolio globally. Sara graduated with a BA from the University of Pittsburgh. Josh Weiner is the SVP of Consumer Analytics at CVS. He is focused on using AI to empower consumers to improve their health and navigate care. Previously, Josh developed biosensor algorithms and wellness experiences at Meta. Josh holds a BS from Carnegie Mellon University and an MS from Northwestern University. Nick Frenzer is an implementation executive at Epic. He is responsible for coordinating the company's population health strategy and execution. Nick graduated from Arizona State University with degrees in accounting and served in the U.S. Marine Corps. Moderating the panel today is Daniel Barasa, Portfolio Manager at Gabelli Funds. Daniel graduated summa cum laude from Berea College with a BA in Economics and Mathematics and holds an MBA from Harvard Business School. Thank you and welcome.
Thank you, Rebecca, for the wonderful introductions, and thank you to our panelists for being here. Nick, I would obviously love to start with you. Interoperability within the healthcare system is obviously a very important topic. It greatly influences the cost of care as well as the quality of care and patient outcomes. Help us frame the discussion today. How would you characterize the current state of interoperability within the healthcare system today? If 0% is we're living in a system where the different entities within the healthcare system are completely siloed off, and 100% is we have seamless integration and flow of data, where do you think we are today?
The journey of interoperability has been really interesting. You know, about 20 years ago, when the concept started of sharing patient records between health systems, the first groups that Epic approached, the compliance officer said it's illegal. And the first CEO that signed on to what we call the Care Everywhere network said later to our CEO, Judy, that he actually signed it by mistake because the CIO just said, hey, I need you to sign this. Now we fast forward and we share hundreds of millions of records every week with Epic and non-Epic sites. So from our perspective, it's been very successful. What's the next stage in that journey, though, because you still have these localized geographies that don't quite connect, or you have a system that's not certified, so it can't send data, is we're very excited about the Trusted Exchange and Common Framework Agreement, TEFCA. So by doing that, ONC, now ASTP, because we need another acronym in our life, is going to have a structure that we can follow more consistently as a country with regulated data elements. I think that's going to make a big difference. What we need to do is agree on what that structure will be and have more groups participate in that. Interoperability happens when people participate. It doesn't just happen magically through the technology. And I think that's the next step that we have to embrace. So it's going well, but there's a ways to go, and it's the right thing to do for the patient.
And Michael, you have the physician perspective. What has the experience been like treating patients and looking for data in terms of their complete medical history?
It's hyper local. In Manhattan, it's actually really good. A lot of the systems here are on Epic and share in accordance with HIPAA. You don't need patient consent in order to share data via HIPAA if it's for treatment purposes. I can tell you in the Bronx, it's not quite as good. Part of that's because some of those institutions they have more stringent requirements than HIPAA, and not as many of them are on Epic. Now, could we share data with non-Epic customers through Care Quality? Of course we could. It's just a lot harder. You can kind of always go somewhere to find health information, but doctors and nurses and frankly, everybody, it's hard to break somebody out of their workflow and have them go somewhere else to look for the information. What I've found is you have to really put it right in their face. So when I have labs, so I'm in New York City Health Hospitals, we show the labs from Mount Sinai and NYU directly in line with all of our other labs. So you don't have to go looking for them. If you have to go click a button, get a consent signed, scan it into the system, people aren't just going to do it. So some places, the technology I think is there to do the correct sharing. I think it's people signing up and actually going following the law as it is written. New York State's got some extra qualifications that you need to do, but once again, it's very doable. But it's not even just at a federal or state level. It is at a very borough-based level, very much about an individual institution and what decisions they've made.
Yeah, and so as we think about how we move towards a more interoperable system, it might be worthwhile to talk about maybe some of the historical barriers that the healthcare system has faced. Josh, I do want to bring in the payer perspective into this. You obviously lead analytics at CVS. What are some of the barriers that are preventing the healthcare system from being more interoperable?
Yeah, and first of all, thank you for being here. I might also add, I think everything else that is true, but perhaps specific to institutions that have implemented, Epic or Cerner or EHRs that have meaningful degrees of penetration, but that's not necessarily the case when you look at other parts of the country or you look more downstream at regional PCPs and so forth.
Yep.
When we think about barriers, I think you commented on quite a few of them, but certainly we still see very limited penetration of patient digital identities within the network itself. And while what you said around HIPAA is true, I also take a standpoint that is pharmacists and nurses and care managers and all still covered entities, but there's only so much we can do if there isn't that digital identity that can connect things beyond what's offered through HIEs or who's enabled things through shared EHRs. So that's certainly one piece. I think the other thing, and someone had said, I think in the last panel, is I'm certainly in the camp of empowering consumers as a conduit to driving more interoperability. And to do that, we need to make the data more useful. And it needs to not just be something that facilitates care and something the providers or prescribers care about, but how may we be able to share longitudinal journeys, offer insights, empower consumers, patients with portability so they can share with their families and their care teams. I think I see that as a major catalyst of driving interoperability going forward. I would say those are maybe the two additional items. Certainly the progress in FHIR and standards, value-based contracting as a means to get more and more networks to agree to share data and agree to common standards or other things over the next couple of years. And I think all of us are probably in the camp of hoping that, say, by 2030, this continues to grow up exponentially.
And then, Sara, obviously, before your current role, you spent a significant amount of time in private equity in finance. So you possibly have the benefit of a fresh perspective to healthcare. Anything to add there as far as what healthcare can learn from other industries to push us forward?
So I think one thing I'll say, and not answering that question, but I come from Henry Schein, which is a solutions-based provider for practices for dental and medical. And why that's important is because we're looking at this whole medical dental integration and sharing of data as a whole body philosophy or approach. And what we haven't done is connected medicine and dental medicine together to really bring data in a holistic manner. And I think additionally, what you were saying, we need to empower the consumers. We need to get the regulations in order. We need to figure out the policies as well as the structures for payers and providers to be able to share that data and get people paid, because doctors and dentists aren't going to do it unless they get paid. So we need to find a way to get them paid as well. But I think there are a lot of things where this needs to be a 360-degree view of many constituents or constituencies who come together to really, bring all of the different perspectives.
Yeah, and switching gears here, just AI as a topic has been a huge focus for investors this year. You run AI strategy for Henry Schein. What are some of the ways that you see the emerging technologies around LLMs and machine learning being employed here to push us forward?
So it's interesting because there are a lot of privacy concerns. There are a lot of, and I know we'll talk about that in a minute, there are a lot of regulations, especially in the AI arena, coming up as it comes to data, patient-specific data, and HIPAA, I think, to Michael's point. But I do think as we bring the data together in a ecosystem, so to speak, there is a lot of power from an LLM that can, do the analysis in a more timely manner than anyone could today, which is going to help enable us getting leapfrogging quicker.
And Josh, you spend a lot of time thinking about how to use AI to help consumers navigate care. Obviously, on the insurance side, you have a lot of unstructured data. Could you maybe speak to how you're deploying these new models?
Yeah, certainly. I guess the theme would be we're using AI to do a better job of synthesizing their data to empower consumers and help them understand how to navigate their benefits and also what information to share with their care team to close relevant gaps in care. I think it's not until recently, there's still so many issues with respect to interoperability, and it's really not until recently that we're able to say to consumers in a scalable way, here's what you need to show your doctor on what's on formulary. So when they're prescribing you a specialty medication, you understand, and they understand in parallel what authorization requirements are, and in turn, what you can get, what you need, and how much it will cost you. So, I think it's kind of one example of solely enabled by AI, empowering consumers, also addressing interoperability. Beyond that, what we've been able to do with our clinical teams in automatically transcribing social worker care management type conversations and using those transcriptions to share with the rest of the care team, both within CVS Health, across the provider group, really kind of addresses some of the patchwork when you think about transitions in care and care coordination. So we see that as another great use case. And similarly, we're aspiring to be able to send an email to those consumers and say, hey, here was that conversation you had with your nurse. Here are talking points for your doctor, for your caregiver, and so forth.
And Nick, Epic sits at the center of all this data. Anything to add there?
Yeah, a couple of things. Where we have seen tremendous benefit is in taking the cognitive burden, especially off of a physician for things that they need to do every day. So responding to a patient message. We actually had to tone the AI down because people said the AI was too friendly and it didn't sound like their physician. But doing things like summarizing a patient chart. If you have 20 years of data, that's hard to go through all that, whereas AI, generative AI specifically, does a really nice job of that. And we have seen some studies conducted at places like Fairview and a few other academic medical centers showing that physician burnout is reduced by about 40%. And you can see that in the reduction in burnout and in the increase in satisfaction. That said, physicians aren't spending any less time because we can see that. But they seem to be happier by doing the work they're doing with the assistance of AI. Where I think we need to be cautious, in my opinion, is one, because generative AI is picking the next word in a series, it should not be used for anything that requires decision making. The AI can't really think, it doesn't dream, it doesn't conceptualize, it just picks the next word. So we need a human in the loop to make a decision. And then two, we have already seen areas where, to the payer perspective, we see a payer deny a claim with AI. And then, not saying you're doing that, but with AI.
We're not doing that, by the way.
A provider with AI appealing the denial, and then we have the dueling AIs doing work, and we have optimized the process that maybe shouldn't exist anyways.
Yep.
And Michael, you have the physician perspective here. We've seen how these LLMs can be used to augment human decision making. Could you maybe speak to specific case examples where you've seen patient outcomes actually being improved by the use of AIs?
Definitely do that. Just give me 1 second on this other topic. So on interoperability, I think where it can be most helpful is on machine learning for patient matching algorithms. Within Epic, it works great. If my patient gets seen at another hospital, I know that patient, it comes across, it works great. You go to our RIO, our Regional Health Information Organization, the patient matching algorithm doesn't work like 40% of the time. Once it doesn't work that much of the time, the physicians stop going, nobody goes, the volume to the RIO plummets, nobody uses it, nobody gets it improved over time. It becomes a lost cause, and that's where we are. So that's machine learning, I think, can really, truly help that. Couldn't agree more on our bots fighting the insurance company bots adds a lot of cost to the system, doesn't actually add any value to the system. The one thing, we always talk about AI to support the physician, and I agree with that, and that is largely where we are today, but that's going to add cost. And if we're not taking work off the physician, we're just making their work a little bit easier, I'm not sure we're doing a whole lot. I kind of, where I would like to see AI go, and this isn't in the interoperability strain, but for diabetic retinopathy, there are 2 FDA-cleared algorithms today, and they've been cleared for like 3 or 4 years now, that if the algorithm says that it's negative, that the patient does not have diabetic retinopathy, the ophthalmologist doesn't need to look at it. You can bill for the service. There is no physician in the loop. They're only looking at the positive ones. I think we need to shift towards that. So same thing with mammogram. We're not there yet with mammogram, but if the AI can call a study negative and let the physician spend all their time on the questionable ones and the positive ones, I think that's how we're actually going to add value to the system and reduce costs, because we're going to save the physician time. Most of the AI I've seen at this point does not have a positive financial ROI. And I think that's a really big problem, because we don't have a margin. So if I don't have a margin, I can't spend money on AI.
And as a practicing physician, have you seen cases where patients have come in and you've actually utilized some of these models to augment your decision-making?
So what I will say is, I think the nice thing about AI is that it doesn't get tired. It's always watching. It doesn't need to like go call their wife or something like that. And that's good. I don't think it's at the point where it's helping me spot something that if I was paying attention, I wouldn't have found myself, but it has attracted my attention earlier to something. The example, I'm an emergency medicine doc. I get a patient with a potential stroke. We put them in the scanner. I go take care of another patient. I get a notification on my phone if the CT scan looks like it's a thrombectomy susceptible stroke. So it accelerated the course to that patient. It accelerated their, I get the notification, the radiologist gets the notification, and the interventional radiologist gets the notification all at the same time before any human has looked at the image. So it's speeding up the process. But to answer your question, I think we would have gotten there. It just would have been a minute and a half later.
Got it. That makes sense. So let's talk about data security. We had a pretty big breach this year with the Change Healthcare cyber attack.
Yeah.
Obviously created a lot of day-to-day operations, significantly impacted day-to-day operations for a lot of healthcare entities. What are some of the lessons that maybe payers as well as providers have learned from that experience, and does it change the way businesses are going to be doing business going forward?
It matters who your friends are and who your partners are. So we have at New York City Health and Hospitals, and I'm sure all the other healthcare systems around here, we have a very complicated layered defense strategy where, we get, I think it's literally thousands of attacks a day. We fend off all of them to this point. But it matters who you share your data with. And we shared our data with Change Healthcare. A large portion of the U.S. industry shared their data with Change Healthcare. Was it Senator Wyden, I think, put it well, which is that they just weren't following cybersecurity 101. They didn't have two-factor authentication. It's kind of inexcusable. So not only do you have to care about your strategy for defense, you have to care about your people that you're giving data to. And we all have business associates agreements in place that says who's responsible for what, but harm is harm. And it really rocked our system for a while.
Yeah. Nick, any insights as far as how Epic has been able to avoid such a breach?
We have a very intense CISO. No, there was a time when I would be reviewing what we call an executive packet with a CEO, and I would probably gloss over the security section. I didn't think it was really what the CEO needed to worry about. For the last year and a half, I have gone through that thing in depth and said, this is a financial risk. You have to pay attention to this. The other thing that I agree with Michael with everything he said. The thing I would add on to it is, I don't know how many people realize that 50% of the financial traffic in the United States went through one ANSI switch. That is an architectural failure that I don't think very many people realize. And I think across healthcare, we have to look at those architectural layers and understand what are our points of failure. And as an industry, we're going to have to step in and say, to your point about partnership, you are my partner. If we're going to keep working together, you better have MFA. You better be auditing your administrator accounts, those types of things. So it has elevated something from a very esoteric kind of technical, I got to do my backup loads, into something that the CEO needs to have front and center. That's a very different role to live in.
And Sara, do you have any insights?
Well, it's interesting because now I'll answer your question about financial services. When I took this job, and I've been at Henry Schein about 3 years, I thought there was a huge opportunity in healthcare. I had been in finance for nearly 20 years and really enjoyed what I was doing. And I think finance is advanced from where healthcare is by probably 10 or 15 years in terms of their data maturity. So it gave me a real opportunity to look at healthcare and say, what can we do to change this ecosystem to bring it, to solve problems, but for people, versus for financial services where it's not necessarily for people or for the care of people. And I think what changed it, and what, cybersecurity was front and center in finance for years and years and years and years. And now it's become really front and center in healthcare. Change isn't the only one. We had an attack. A lot of hospitals and health systems have had attacks recently, and it's becoming very prevalent in the healthcare ecosystem. And we have to address those, multi-factor, do you have the right agreements? Are you picking the right partners? So I would agree with everything you all said.
And the urgency is so important to that, because what AI is going to make easier? Cyber attacking.
Yeah.
Correct.
It writes great code and it writes a lot of emails. So we better be ahead of that.
Yeah.
I guess I would just say it's tempting to talk about AI and all the shiny objects, but like in our systems, insurers, most providers and so forth, we still have such a shaky foundation and like decades and decades and decades of underinvestment. I mean, we're just talking about different things. I mean, I'm sure all of our companies still have stuff that's written in COBOL, most of you don't even know what COBOL is. Something to keep in mind still.
Very good point. So let's talk about the pharmaceutical industry. Obviously, lots of innovation taking place. We're moving closer and closer towards more personalized medicine. We're leveraging individual genomics to create these medicines. In that world, as we move through that, pharmacy trend will be a very important topic. How do you think about value-based pricing and how we pay for these innovations?
Think about it a lot. Yeah, certainly one of the things that keeps me up at night is how we pay for, increasingly expensive but extremely transformative cell and gene therapies and really curative medicine. And yeah, trend. I mean, now we see what's happening with GLP-1, and I see this as just another wave. I think the best thesis out there is value-based, contracts in the construct of how we negotiate with pharmaceutical manufacturers, but that can only happen if we have some of these interoperability unlocks. We have to be able to, one, use that data to truly assess real-world endpoints, to establish whatever we're going to characterize as benchmarks and performance guarantees tied to this larger payment. And two, it may also create the foundation by which we can do more elegant things from a risk-sharing perspective, particularly as people. The average tenure of someone, a commercially insured life is only a couple years. Medicare is maybe 5-6 years. So it also has to create a construct by which we can share in this risk and outcome improvement as people move across different insurance products.
And Nick, Epic is doing some work around mapping the human genome to different diseases. Maybe you could speak about that and how you think about pricing as well.
Yeah, it's really exciting. What we've been able to do is anonymize and de-identify hundreds of millions of encounters, billions of patients. And then by mapping that to the genetic studies, by having discrete data coming into that database, we are able to see markers that have trends. And then we can build that decision support in for physicians. So for example, being able to say, hey, this patient has a genetic indicator that suggests that this medication will not work for them. And, I like how you put it, that might just get you there faster, because otherwise the patient might have taken that prescription for 90 days, had to come back, see the doc and say, that's not being effective. So that is how we're thinking about some of the genetic work. But it really comes back to interoperability in terms of how do we safely continue to aggregate that amount of data and provide it for the right research. So it's not for sale, it's for the research purposes that we can then build better decision support. That's how we're thinking about it.
So I said I look at this from a dental perspective, but I think really important, your mouth, your head is part of your body. And we're seeing a lot of research and we're participating with a lot of people, FDI and others, where we're doing studies, World Economic Forum, but really to think about what diseases can be addressed by what you identify in someone's mouth, caries and other things, related in your normal dental exam. But we're seeing diabetes, cardiovascular health, and maternal health are three big areas where we think there's connectivity.
Yeah. I think clearly a lot of value in precision medicine with if you have this genetic profile, this chemotherapeutic agent will work better. But even just more simply than that, when you come in to be seen, which statin are you on? And has it caused a problem with you before with the other healthcare system you were at? I think we're still at the space where at the very basics, just interoperability, knowing what patients have been on, knowing what their allergies are, that's still where we are at for most patients. Yes, it's great for the more complicated big institutions to do some of the precision medicine stuff. But I think there's certainly value there. But I think more of the value is still based on the basic blocking and tackling of interoperability.
And just from a data governance perspective, I know Henry Schein does have an AI committee that sets the guidelines as far as how you can use patient data. Could you maybe just speak through that?
So when AI hit everybody and it was, it came fast and furious, and generative AI really brought it to everyday people's hands. But in all reality, AI, machine learning, all of these things have been around for years and years and years and years. They just weren't readily available to everyone. One of the first things we did, and I've spent a lot of time either at, events and talking to peers, many people went chasing the generative AI, kind of bandwagon to say, what can I do and kind of be in front. But what people found out is exactly what you said. The ROI on AI has been challenging. But also when they take these AI models and these AI capabilities and try to put them into production, they often don't get there. Two things about it. Most of them either have ethical or regulatory issues. So we took a different approach, which was let's come up with the governance structure first, and then kind of step in slowly to AI so we can, understand what's coming down the pike. And if you look at regulation today, Europe is way far ahead of us. Germany and France have recently made significant moves towards stricter regulation. In the US, you're also seeing a number of states, because we're very differently organized, coming out with their own regulations. New York, I think, has 50 potential regulations kind of being discussed right now related to AI. So there's a lot there, and people need to be cautious before they're just jumping in 2 feet ahead of, 2 feet at once.
Any concerns around any ethical concerns, or even just any thoughts around data privacy and ownership of the data?
Yeah, it is so important that we are only putting patient data in a healthcare specific model that is contained. The high likelihood of disclosing HIPAA protected patient data into the greater large language models would be a very negative effect. So we have to be careful about that. We do very deep ethical reviews at Epic to ensure that the AI that we're producing does follow those guidelines. We evaluate it for bias, so on and so forth. But when I think about governance, what I often see is some groups have jumped to a model where there is now an AI officer and there is a council of people that are going to make the AI decisions. I think that's a mistake. We all have to embrace AI, every single one of us, if we're going to stay ahead of it, right? And I think that it is better for the operators in the different business functional areas to be deciding what AI should be used, with support by experts in ethics and other types of areas. But if we don't spread the AI governance across the organization, it'll either get bottlenecked, or I think it will be the IT days of old, where IT makes a decision without consulting operations.
I agree.
Yeah.
But we don't have enough across business units right now. You don't have heads who understand the impact of AI yet. So I think you have to step into it slowly. I think that's where we get to in 5-10 years, maybe less. But I think we have to get there slowly, because if we say, okay, business leader, make a decision, and they have no idea what the decision has impact, regulatory, privacy, HIPAA, et cetera, you're going to have problems.
That's true. It needs to be multidisciplinary.
Correct.
Yeah.
If you have the AI officer, or that title, go talk with your clinical counsels or your revenue, like your surgery group, your ED group, or whatever group it is, they're the ones who should make the decision advised by the AI person. But it's not the other way around, to Nick's point. Otherwise, you're going to have the technical people telling the clinical people what to do, and then you get yourself into an awful lot of problems, especially in healthcare. You have to think about what your healthcare system, what is your core business? Our core business is not and should not be artificial intelligence. It should be taking care of patients. And I think each one of our companies should decide what their core business is, and then go out and partner and get the relevant expertise in other areas. But yeah, I think you have to realize where your nidus of control is. On the bias topic, I think this is kind of glib, but like the algorithms and everything we do is it's as biased as the data sets on which they were trained, which is from our society, which has biases. Like, we could go down this for a long time. But I think the job here is not to get rid of bias. It's to understand what the bias is and try to mitigate that bias. The example I'll use is there's a no-show predictive algorithm. It's from Epic. We haven't even tweaked it. We just rolled it out. It works pretty well. It predicts whether you're going to be a no-show or not. We're on version 2. I think this version has really it's got no race, it's got no ethnicity, it's got nothing like that, but there's strong correlations to those things. So if we rolled out the algorithm today, it would, which we have done, what it would show is patients have a higher chance of no showing if they're from a lower socioeconomic group. That's the fact. So some groups I've seen, they went through and said, okay, we'll double book those slots, which makes some intuitive sense that if a patient's got a 50% chance of not showing up, you schedule 2 patients in that slot. But what you've done is you've reinforced that bias. Those patients get a worse experience. They're even more likely to not show up next time, right? So that's not great. What you can also do is take that same algorithm that has bias, but what we have done is we make a phone call to the patients that have a high risk of not showing up. So that mitigates the bias. So I think you can use a biased algorithm in an unbiased manner.
Does a person make the phone call or does it?
I was involved in this decision and I forbid robocall from being part of the trial. We did a control where we had normal reach out, like text message, all that kind of stuff. But these were new patients that specifically, this is the most helpful, where they weren't getting the text message, they weren't getting the email, or they were getting the email, but nobody reads emails. But we made it a phone call and it's great.
Josh, I want to bring in the payer perspective here as far as bias is concerned.
No, honestly, I think it's been well stated. I think there's a role for regulation to play. And, I hope our government will step in and do the right things and find the right middle ground. I think Michael said it really well.
Very
right?
good.
With respect to kind of the textures of bias. And I'll just reiterate, because the provocation was made earlier, at least at CVS Health, we never have and never will use algorithms to deny care or be part of prior authorization related processes.
And as far as regulation goes, we typically almost always talk about HIPAA, which has to be about 30 years old by now. Nick, anything to add as far as what can be done from a regulatory perspective to kind of push this forward?
Yeah, the interesting thing right now is, yes, HIPAA works, but it is becoming quite dated. There are regulations across the different bodies that regulate healthcare that are at direct odds with each other about what data can be shared. When can you share substance abuse data? When is an attributed patient in a value-based arrangement your patient that you can evaluate? All these things really need to be evaluated. Now, I have seen over the last couple of years in DC a much more cross-agency collaborative effort at rulemaking, which historically did not happen, which was another regulation. But that is going better. I think with the new administration coming in, we need to see what cross-agency collaboration is going to happen to allow data sharing to happen more efficiently. Will we continue on the path with TEFCA under ASTP? Will we continue the data sharing trends there? Will we evaluate the rules that are directly in conflict with each other that we and hundreds of healthcare systems have signed on to letters to say? I think that remains to be seen. But I am always an optimist. I am hopeful that we will continue down this track because it is bipartisan. It is the right thing for the patient, but it will require new leaders to be introspective about what regulations are in place and what is at conflict with each other.
You mentioned the new administration coming in. We obviously had a very important election last week. And then obviously last night we had the nomination of RFK Jr. to be the Secretary of HHS. Maybe just digging into that, what are you hoping to get out of the next administration in terms of kind of helping us move forward towards a more interoperable system?
He's going to start a value-based care polio clinic.
Quite the suggestion.
But my true hope is that regardless of who is in the seat, we remain focused on the right thing for patients.
Yeah.
A tangible example of that is the improvements in CMS policy around health equity, building that into the MSSP program, requiring to do SDOH screening on patients to help get them care coordination that they need. That was a huge step forward, and that took some grit by the people that did it. That's the type of thing that I hope the next administration will continue. But I don't know, I never met RFK Jr.
Any thoughts around the
I'll go what I'll
policy?
hope for. I think historically we've had protected classes of patients, which are psychiatric patients, patients with HIV, substance abuse disorder. And for those protected patients, we wall them off and don't share their data, which to me looks like hurting those patients. So I don't quite understand why we take correctional health patients, why we take some of our most vulnerable patients and then deliver inferior care to them. So my hope would be we loosen the restrictions in those areas.
I could go in one or two ways, but I think my hope is really as we think about the interoperability and sharing of data, Nick's right. We really need to figure out ways that can be a standard across the ecosystem, because otherwise we're going to be spinning and spinning and spinning and really not keeping the patient at the center of what we're all trying to accomplish. It's funny because we're talking about HIPAA a little bit here, and yes, HIPAA matters, but as we introduce AI and we introduce other things and really try to determine who owns the data, who is, who has the data, you're going to introduce other regulation that's really going to have some overall impact on where we end up.
I think we got to keep pushing on incentives. I think that's the right role, and we need more incentives to address the issues that have been discussed here, both interoperability, data sharing, and like the continued issues with underserved populations in areas, of lower socioeconomic status.
Got it. And that is a good segue to health equity. I know, Nick, this is something that's close to you and you'll be very focused on. How does health equity play into all of this?
Yeah. There's a quote that is well-founded that your zip code matters to your health more than your genetic code. And that data bears out very strongly. And that is sad. So what the approach that we are taking is democratizing the data around things like the social vulnerability index, area deprivation index, these different ways that we can evaluate a geographic area, whether it's a census tract or a zip code, to say what are the areas that are most at risk, and then overlaying that with, Michael, kind of what you were talking about, scheduling and other efforts. But where I'm seeing the most success is when organizations are investing in a care management structure to evaluate those populations and deliver care to them. And that care happens very locally. Sometimes that food bank that is down the road is far more important than the physician that is in the hospital 2 miles up the road, right? So being able to connect with those community-based organizations is something that we have focused on. I am so glad that it was included in US CDI v3, so it's now a regulated data set. We released it a couple of years early to try to push that ahead. So I believe that when we think about health equity in terms of transparency and visibility, and we have leaders that are willing to not ignore the problem and say, yes, there's a problem and we can do something about it, there is meaningful change. And in New York, for example, there are a number of organizations doing this that I work with personally that have focused on the areas and the populations that are just not being served and invested in getting time out in the community to help them. Bring the physician and the food bank into the conversation together, leaning on the food as medicine program, for example. So, but on the other hand, where I see it not working is when people don't want to acknowledge the problem, or they say, oh, those folks don't have phones, or we're just not going to be able to reach them. We can't get into that neighborhood. That's how we got into this problem in the first place.
Yep.
Anything to add?
Yeah. I think patients that are wealthier with commercial insurance tend to seek care and get really good care. I think anybody who shows up at our hospital will get really good care regardless of what insurance you have. But what is true is that patients with Medicaid or uninsured seek care less. And we never really knew what they were doing. But with interoperability, I can more targetedly reach out and say, this patient didn't have their mammogram this year, or this patient didn't have their colon cancer screening, and really know that with a good degree of confidence because I'm getting data, I'm getting records from all the other regional health systems in the area. Then I can do a targeted outreach to those patients and get them in. We've all talked about the transition from volume to value for a very long time. But to me, what this means at this point is reaching out to the patients proactively that aren't seeking care and getting them in for those right screenings. The other thing I'll touch on here is on specifically high on equity is that homeless patients, they seek care at a very wide range of institutions. And without interoperability, you wouldn't see that. So interoperability for people that not only just move around a lot because of their socioeconomic status they're required to, they get the most benefit from us being more interoperable.
I think medical dental integration as part of interoperability is really important. And why I say that, your dentist, the statistic says your dentist sees you more often than your doctor. And if you start to think about, you want to treat, you want to move towards value-based care, you want to think about this in a different way, if you're seeing a doctor or a physician who is trained in some way, a dentist is still a doctor, right? That they can do some of that basic screening in places that is much more accessible than having to go to the ER because there's something really wrong with you, or having to, go make an appointment for a colon screening. But you can do that up front. And I think that's why we've been pushing medical dental integration. And then Henry Schein itself also goes similar to Epic, goes out into many places to support, low income populations to try to provide care to those individuals so that we can, have that influence and really be seen, have those patients be seen.
Josh, CVS has been making significant investments into wearables, connected devices. How does that all factor into pushing us forward?
Still thematically, the premise is, can we empower consumers with their data and with their insights? Does that drive better outcomes, better access, and help lift all ships? I'm extremely excited, about the future for wearable devices. I think everyone's seen the progress that's been possible by studying pulse waves and what that does with respect to cardiovascular disease and movement and the number one leading cause of death. I suspect you're going to see a new wave of this tied to a new set of computing devices and new wearables that starts to look at new organs, establish new biosensors. And I think that feeds well with new incentives tied to remote patient monitoring and ways that providers can partake in this too. And I think it's through technology and through consumers that will more effectively connect pharmacists and providers and care teams and families. And I certainly believe in this philosophy of the consumer being at the center to address much of this.
And then Nick, how do the wearables and the data that you're collecting from that filter into your system at Epic?
Yeah, so we did very early integration with Apple and with Google for their health kit to be able to bring that data in. So if you think of it as there's going to be this universe of wearables. I'm wearing one now. I remember my wife had a cardiac monitoring thing she had to wear for a couple of weeks, and they're all going to produce data. What interoperability means in this case is app to app, application to application connectivity, so that we can take that data, whatever it may be, and then map it into the patient's chart, because everything is ultimately about that patient's chart. Then there's the question of, when do we surface that in my chart to say, hey, you had an irregular ECG reading based on the data we got from the Apple Health Kit. And we send a message to Michael to say, hey, your patient had an irregular reading. They should be calling, otherwise reach out to them. That is the power. And it is growing so fast, and we're making advances every 6 months that is really incredible. But in many cases, if the technology being developed in the ecosystem does not consider the interoperable needs of the patient's chart and how that interacts with the healthcare system, we'll end up in another spot where someone will develop a really cool wearable device or some other thing, but it won't be able to connect because it wasn't designed with interoperability in mind. I'll often talk to companies at the seed or startup stage just to give them some advice on entering the market. And what I tell them is, we at Epic really want you to consider the interoperable means so that you can connect with us. But you need to start there as you're developing your technology, rather than do something in 3 years and realize you have to rebuild your entire technology stack. So that is often my advice to entrepreneurs, is know the landscape of what you're getting into before you get so excited about building something, but it doesn't actually interoperate.
So I think about it similarly, but a little different. The patient should be the center, and we need to empower our patients with devices. I have 2 on right now, but we need to empower people to own their own data and then contribute their data to where they think appropriate. Take it to their doctor, take it to whomever, because you may not have a doctor in the same, no offense, but they may not be in the same medical system, right? You may have doctors in 2 or 3 different medical systems that aren't connected with Epic. So then what do I do? Mm-hmm. So we need to empower patients to be able to bring their data forward and get incentivized to be able to share it. And then it starts to drive additional outcomes from that data.
There's too much data. It scares people, because then you're sitting there saying, okay, I had this crazy blood pressure reading and we didn't do anything about it. Am I liable now? So I think when you're talking about regulation in this space, what you have to say is there's tons and tons of data. It is good that we collect data. We should not be liable for every bad reading that's out there. And I think this is where you need AI to surface the right stuff. And this isn't complicated. This can be like really rules-based artificial intelligence. Some would not even say that's not even artificial intelligence, and surface the right thing to the doctors so they can intervene if it's a problem. It's going to create a lot more need for healthcare, but hopefully we target this at the patients who are most at risk and can benefit.
I do want to open up to questions from the audience. There are mic runners, just raise your hand.
Good afternoon to you all, and thank you for speaking. Nick had commented on, as well as Michael, the intersectionality between AI and physicians. For me, as a public health master's student, I'm at least always critical of specificity and sensitivity when it comes to tests. Right? How do you, I guess, address that intersectionality between the two and making sure that from a patient-centered care perspective, there isn't an over-reliance, much less an under-reliance on either of the two?
I can take a shot at. I think when I think what your question leads me to think about is how a physician in many cases, or a patient for that matter, when they're interacting with MyChart, is going to interact with AI-driven information in a way that helps them but doesn't create additional load. We ran into a bad spot where we found some groups had so many pop-ups that nobody looked at anything. They just closed it all down. So for me, this comes very much into a product design of what are the heuristics of how am I presenting it in a way that first off, a physician in this example should know that was AI generated content. It should have sources and citations, but how do we present it in line with what they're doing so that it makes it easier for them? If an end user has to think about using AI to use AI, we will not have made it easier. So for me, it comes down to workflow, making it seamless, and doing detailed measurement of the time in workflow and of the cognitive load that we need to. Simple solutions are better.
Yeah, what I'd add is specificity over sensitivity all day, every day right now. If you take a doc and you start to tell them all these alerts that are wrong, they're not going to pay attention to any of them going forward. I remember this wasn't artificial intelligence, these were just the alerts. But I remember at one point we rolled out this whole big group of alerts. This was a number of years ago. And a doctor missed the patient was on 2 blood thinners. And we're like, well, we had alerted them. We sent them an alert. Like we'd also sent them 30 other alerts in the past 20 minutes. So we trained them not to look at it. So I think at this point in where we are, I would really favor trying to be very specific with our alerts and not as sensitive using artificial intelligence.
I'll just add, I think for us, we think about AI as a way to augment decision-making rather than any form of autopilot, if you will. And I think it's in part because of the risk you're raising.
Should be okay.
Okay. So I moved from Boston to New Haven and went from Harvard to Yale for my care. They both use Epic, and yet the doctors at Yale don't know what happened to me when I was at Harvard. They both use Epic. Now, I know why they don't integrate the data. Now, I can go into MyChart and I can see my Harvard data or my Yale data. They're not integrated, even within Epic. And it's legal because the doctors at Yale don't want to be responsible for the data that was put in at Harvard. Until those legal issues are resolved, there's not going to be the kind of interoperability that prevents contraindications from killing a patient. The only solution to this is a health data record bank where the records are in something like the Health Information Exchange, are pulled into the record at the time of admission, appended there, and then they go back into the cloud. Is there any chance that that will be implemented before I die?
Legally, we're fine. That's a bad institutional decision that you're describing.
Right. That's live. It exists today.
Yeah. That's just a bad institutional decision. You're legally allowed to do what you just described. They should be doing that.
The systems choose, right?
I think you're right. I think I don't know those two particular institutions, and so I'm going to talk generically here, but people are concerned sometimes that they didn't look at the data, right? Like if it's in there and I could have had access to it, maybe I'll get sued. And you know what? I've heard that argument from lawyers before that you should have looked. yes, some regulation around that would be helpful. My view overall, and this is not the purpose of this panel, but medical legally, we get sued for bad outcomes, not bad processes. So I would rather have fewer bad outcomes. And I think in the whole, that will make us better.
Hi, Sara, I'm so happy to see you here. I'm a dentist who's in public health. I've been working in this space in New York City for 15 years, and I've been talking about integrating and interoperability between oral health, diabetes, cardiovascular disease. I worked in Mount Sinai in the Department of Cardiology for 8 years, and I have found barriers at every step when I talk about this. They just think, oh, you're a dentist, so you're seeing a patient in a clinic in a chair, and they don't see the larger picture of how this can be integrated. I know Epic has Wisdom right now, and I don't know how easy it is to transition between one and two because I've used Epic, but I haven't used Wisdom. So my question is, what are the facilitators that you see that we can use oral health as a space, especially when you brought up, you see a dentist, especially if you're a child, you have CHIP. So how can we prevent diabetes at an early stage to reduce healthcare costs? And how can we bring this up in forums like this? You have no idea how I'm delighted to see you here, because I've been going on and on about this for 10 years. And what can we do as public health professionals, as people who want to reduce the healthcare cost burden across the spectrum, to sort of talk about interoperability, talk about more innovative methods, and use tools that are cheap, like you talked about food banks. Now, that's something that I work with community leaders. They will not go to Interfaith Hospital or One Brooklyn Health, but they'll go to the corner grocery store if you talk about Brownsville or Crown Heights. So it's a general question, but I just wanted to know what your experiences were in facing barriers and facilitators to using different methods to improve equity.
So I talked about some of them earlier, but Henry Schein and a whole bunch of people in the ecosystem are working together. You can see people like the ADA. You can see other associations in the space, as well as many dentists and DSOs who are very interested in trying to bring this together. The World Economic Forum has an initiative right now where they're talking about this interoperability between dental and medical medicine overall. And then also, I think, while I understand the Epic ecosystem and it's fantastic for hospitals and people who are on that, we do need to bring it up a level and start to think about it. How do we do this not just in Epic, but across the country and then to a broader scale across the globe? And the constituencies who really matter, they're technology companies, they're hospitals, they're payers, they're providers, and you have to do providers at every level. It's not just your DSO or your, large system, but you have to look at your local practitioners as well, because they all look at it differently. And you're starting to see some real good momentum with many people who are doing some studies to really bring a highlight to this, but also to, encourage government officials and politicians and others to look at the legislation associated.
I'll maybe say one thing. You may seek inspiration from the pharmacy model. I mean, there's continued growth in pharmacies directly contracting with health plans to receive some form of remuneration for supporting preventative care and things that are correlated with outcomes. I haven't spent nearly as much time with respect to like the actuarial science of dentistry, but.
And I'll add, it's not just dentistry, to his point, pharmacists, other people who are trained medical professionals, where people go every day to get care, are places we should be looking at so we can get to this value-based care model where we have health equity.
I think there's just a huge opportunity to leverage dental medicine for value-based arrangements that just hasn't been realized. Like, it's just not discussed in many rooms, and I think it should be. Like, if you have a severely diabetic patient that's coming in for a cleaning, that's a great opportunity as an ACO or a CIN or whatever your organization is to care for that patient. It's just not often discussed in the room, I think.
You have a question right there? There you go. Go ahead.
Hi, I'm Sandilya. I'm a data analyst with Johnson & Johnson. My question for you is, if all your analytics dreams would come true in terms of data analytics and generative AI towards improving patient care, how would that dream look like? And in reality, how far are we away from that dream?
Who's going to wave the magic wand?
Yeah. I guess I'd say, tell me who needs what, when, and if they've not already gotten it somewhere else. That would be amazing. This gets into the value-based care contracts. Cancer care is great. All these other, vascular surgery, all these really complicated things we're doing are wonderful. But if you're talking about the greatest benefit to the greatest number of people, it really is diabetes management, hypertension management, cholesterol management, making sure we're doing the basics right. And I think overall, the government has done a good job and the insurers have done a good job on those value-based care arrangements on picking targets that make sense.
I agree. And one thing that I would love to see would be a continued push into evaluating clinical and other operational data as the basis for how we're making judgments, as opposed to a CMS 1500 form being described as the patient's clinical acuity. Like we have, to put it another way, we have pretended that claims actually show how sick someone is, when now we have very robust clinical data we should be using to do that. If we could make the push into that form of analytics as how we're making decisions, how we're reimbursing for care, that type of thing, that is a world of analytics I would really like to live in.
I think, I agree, but it's really how do you get predictive and not reactionary to someone who presents in front of a, hospital doctor, et cetera, et cetera. Like, how do you know what is going on in their body and to be preventative of what could come in the future?
We have time for one quick one.
Okay, hi. I wanted to say thank you for being here. And also my question's kind of for Nick and maybe a little bit Josh. I like that you brought up startups in the entrepreneurship realm, and especially under TEFCA. I've been following the developments and I'm really excited to ask you, as a QHIN in the partnership agreement, is there room for you as Epic and the other QHINs as well as participants under that model to negotiate that partnership agreement? Because as much as we strive for interoperability for those patient outcomes, you brought up the wearables, those companies and those wearables that are gathering this data, there's a difference between wearables that require HIPAA compliance and those that do not. So everybody wearing an Apple Watch doesn't have HIPAA compliant regulations on that. And so you as Epic might gather that data, but there's that trickle down, who's responsible, how do you monetize it, and what does the regulation look like on that, which is what I'm doing. So happy to chat with anybody after. But I kind of want to know, especially from Epic's perspective, how are you operating in that? Are you seeing any pitfalls or gaps in the TEFCA framework that you wish to see improved?
Yeah, it's a great question. So our QHIN is very focused on our Epic customers, and that's because we want to service that architecture. We don't want to charge for it. We want to make the Epic Nexus QHIN the way that Epic customers can share data with everybody else into the TEFCA network. That said, what we're seeing more recently is the need for liability acceptance at the subcovered entity level is a significant one, because we recommended a rule change because basically what we were finding was the overall hub organization that maybe has 10 organizations under it was not going to take liability for the subsidiary 9 or 10. They had to take acceptance. So I think for the other QHINs and what you're doing, the question will be, what is the liability acceptance that's going to live beneath that QHIN level? Who are those organizations? And what is the proactive auditing that needs to happen to make sure that we don't have a law firm taking 40,000 patient records to go reach out and start a lawsuit? That's the type of thing that I think we need to do. And that is partly one of the adoption challenges that we're having right now with the TEFCA model is how many QHINs will there be? What is the liability acceptance that's going to live at each level? And what will the regulatory penalties be if someone breaks that? We don't know that yet. And I think that we need the next administration to decide that very quickly if we're going to launch.
Thank you so much. We'll take a quick 10-minute break. Our next panel starts exactly 11:20. In the meantime, I want to thank our panelists. Thank you so much.
Jeff Jonas is a portfolio manager at Gabelli Funds. This podcast is an excerpt from Gabelli TV that appeared on December 9th, 2024. Gabco is providing these links as a matter of general information. We do not intend for these links to be a complete description of any security or company, nor is it a research report with respect to any of the companies mentioned herein. As of September 30th, 2024, affiliates of Gabco Investors Incorporated beneficially less than 1% of all companies mentioned. The analysts' views are subject to change at any time based on market and other conditions. The information in this posting represents the opinions of the analyst and is not intended to be a forecast of future events, a guarantee of future results, or investment advice. Views expressed are those of the analyst and may differ from those of other Gabco officers, analysts, other employees, or the firm as a whole. Because the investment personnel at Gabco and our affiliates make individual investment decisions with respect to the client accounts that they manage, these accounts may have transactions inconsistent with the information contained in this posting. Certain Gabco personnel may know the substance of the posting prior to its posting. This webcast is not an offer to sell any security, nor is it a solicitation of an offer to buy any security. Stocks are subject to market, economic, and business risks that cause their prices to fluctuate. When you sell shares, they may be worth less than what you paid for them. For more information, a prospectus, or summary prospectus, visit our website at www.gabelli.com or call 800-GABELLI or 800-422-3554-914-921-5100 fax 914-921-5118 info@gabelli.com.